Great. Thanks everyone for joining us today. Today's BRiTE Center presentation is done by Dr. Tyler McCormick. Dr. McCormick is a professor of statistics and sociology at the University of Washington, where he is also a core faculty member in the Center for Statistics and Social Sciences and a senior data science fellow at the eScience Institute. In today's talk, Dr. McCormick will describe a method for making statistical inference in regressions using output from a large language model as a response. Specifically, he will discuss the use of narratives known as verbal autopsies to predict a cause of death and then perform inference using these predicted outcomes to understand population level trends in mortality. Today, he's also joined by two of his students, Kentaro from the statistics department and Adam from the sociology department. So with that said, please take it away.
Yeah, thank you so much. I really appreciate the chance to be here. And so let's see, this will go through, right? Yeah. And I might stand up and walk around at some point. So that's yeah. So this is our team for this project. So a couple of the faces you'll see here. So Kentaro's over there. He's a postdoc that's been working with our group for about a little under a year now, and then Adam is a first-year PhD student in sociology, but that's culminating a series of bad decisions by Adam to continue working with us in areas of practice for the past 3 years or so. All right, and then Trinity, Steve, I should say, Jeff and Steve are both at the Fred Hutch, and Trinity's a PhD student in stats, and Lilu is in the maternal and child health division at Johns Hopkins. Okay, so this is meant to be sort of a very high-level introduction to the way that we think about the issue of how do we do inference with predictions in general, but especially predictions from language models. And so, being a statistician by training, the first thing I like to think about is sort of where do research data come from? So what's the process for acquiring research data? Since that's that's sort of where lots of the statistical challenges come from. And so if I don't know if anybody else happens to have had the pleasure of going through a stats PhD program, you'll definitely know this. But if you've taken a stats class, you might know that the stats perspective on this question looks something like this. So unfortunately, we tend to sort of teach statistics in a sort of given data way. So given some data, run some models, given some data, do some asymptotics, given some data, do something else. But that's of course not how research works in a large variety of contexts. Sometimes you're fortunate to be in that position, but often it's not. And so what we like to think about is what we see as a big challenge is that sort of in many sort of statistical problems, we use the data that we want, that we actually have, that we can easily access to try to predict the things that we can't. And so then these predictions then get used for downstream analysis or sort of policy decision making. And I'll give some examples of that. But just to kind of summarize the main problem, this is sort of what we see, right? So some function, think of it a fancy statistical model of the data you can get. And since this is a talk about AI, that function probably looks something like this. No idea what's going on there. And, it could be, much more complicated, of course. Some function of the data you can actually get gives you the thing that you actually want-ish. And so that's kind of where we live, is in that ish part. So trying to understand that distinction between what you can actually sort of practically and financially collect as part of the research data enterprise and what you can what you would like to do inference about. So we have a nice analogy that we've come up with in our group for how we think about how this problem is sort of different than the sort of classical sort of statistical inference problem, right? Because I think that's one of the things that is challenging when you're trying to explain what we think is a sort of a new sort of set of, or at least a newly very popular set of challenges in using predictions for downstream inferences that people sort of tend to latch on to what they've thought about before, right? And for lots of folks, that's the sort of classical inference paradigm, right? And so this is an example. This is a picture from 1515 of a rhinoceros by somebody who, as far as we know, had never actually seen a rhinoceros. But this is actually from a woodcutting based off of descriptions by people who had actually seen a rhinoceros, right? So it looks, more or less like a rhino. It's kind of got like a nice little unicorn horn up there, which I think my daughters would be super psyched about. But this is kind of our analogy for the inference paradigm, right? So we've seen some examples, right? We have some firsthand experience with the thing that we're trying to learn about, and the uncertainty comes from the fact that we don't see the whole population, right? There are rhinos out there that we haven't seen, but we have good evidence that's directly collected by people who have actually seen one. And you can avert your eyes, Kentaro, because I'm in love with this picture so much that I know this amount bothers you.
I can do work.
So this is a picture. This is a picture that shows a rhinoceros that's drawn by prediction. So this is from a series by an artist who tried to draw modern animals the way that we draw dinosaurs, right? And so the idea here is that this is a picture of a rhino by someone who's never actually seen one before, and not that the person drawing it hasn't seen one, but that nobody has seen one, right? So you have a lot of indirect evidence. We have fossils, and we know about other animals. Maybe we have a large literature, which maybe is biased, maybe isn't. And so attempting to draw something like a rhino without ever having any sort of firsthand experience. And so I think the reason I like this analogy is because I think if you look at the first picture, it's sort of, you can recognize that animal, right? If I say like, what's that's a modern animal, what is it? Whereas it's not really clear if I gave you that picture, that you would come up with a rhinoceros, right? And so I think this sort of is a nice way to sort of think about the exercise that we're doing, right? We in some sense are, when we make these predictions, we're trying to sort of generate something that's new, right? That's very different than the statistical inference paradigm, where we're trying to say, how different would the world look if I had gotten a slightly different piece of direct evidence? We're sort of generating something that's sort of not there in the prediction. And there's really no way. The other reason I like this sort of comparison is because there's really no way in the vast majority of cases to know whether or not you're right? So like, we can't just say like, oh, I'm gonna go down the block and see a dinosaur and like see if this is a good way of drawing it or not, right? So so that's kind of how we think about the way that this problem compares to the sort of standard inference paradigm. All right, so that's very, very high level. Let's make it a little more concrete. So a lot of our work is in the context of global health. And so I'm going to talk today about a very specific kind of global health measure called a verbal autopsy. And as context here, it's important to realize that in a large fraction of places that don't have comprehensive recording of births and deaths, lots of deaths in particular are not assigned a medical cause. There's not a sort of routine recording of this person was alive, they were born on this date, and now they're not. So this is a 2007 paper, so it's changed a little bit, but I think it's sort of still roughly the right order of magnitude that fewer than a third of the deaths worldwide are assigned a medically certified cause. So it's not this is approaching 20 years out of date, so I think this has changed a bit, but I don't think it's I think it's a fair statement to say that it's that the majority of deaths worldwide are still not assigned a medically certified cause. And this, of course, is going to be the burden here is going to be highest in places with the fewest resources, right? So this is on the x-axis here, you see your gross national income per person. On the y-axis, you see the estimated coverage of the registration system. So what fraction of deaths are recorded by the sort of system that routinely reports births and deaths. Not surprisingly, as you increase income, the sort of fraction goes up. But for lots of places that are resource constrained, the fraction of deaths that are covered is very low. All right, so a verbal autopsy is one way to try to learn about, ascertain cause of death in settings where deaths are not recorded. And there's sort of two primary motivations. One is to sort of try to address this inequality in the reporting of births and deaths. And the other is because, if you don't have sort of this basic public health information about, the things that people are dying of, it's very hard to do any sort of public health intervention. I mean, it doesn't change your ability to do the intervention. It dramatically changes your ability to know whether or not the intervention works. So verbal autopsies are one tool that are deployed in these settings. So on the left here, you see a picture of where verbal autopsies are deployed geographically. The verbal autopsy has a few different components. So the standard verbal autopsy is a questionnaire. So there's a questionnaire that takes about an hour to complete that asks detailed questions about the circumstances around which a person died. So typically these are conducted with a family member or somebody who was a caregiver of the person. So they'll ask things like, did the person have a fever? Were they in a car accident? Did they interact with the healthcare system at all? Questions like that. The survey is, like I said, the survey is very long. It's not calibrated it's not sort of dynamic in any way. So everybody gets all the questions. And so that can be an issue because these are sort of places that are already resource constrained. You have to have a trained enumerator to go and spend, an hour at least kind of going through this process. You can imagine it's also not a pleasant experience for the person that's doing it. And it's also very regimented. It has to happen. Like the only way you can conduct a verbal autopsy interview, since it's so long and so specific, is with a dedicated team as part of a verbal autopsy survey. Right, so you're very limited in the context in which you can conduct these things. There's also an interview. The interview currently, as it currently states, is essentially an add-on to the questionnaire. It's sort of a free response narrative that says, "Hey, tell me about what happened," that kind of thing. And it varies a lot depending on the context of when and how that's asked, but that's the high-level picture. So then what happens is a clinician will label a sort of training set of these verbal autopsy interviews and say, well, we think, based on this questionnaire, this interview, we think this person died of say a cardiac related event, or this person died of an infectious disease, that sort of thing. And there's an algorithm or a set of algorithms that assign a cause based on the inputs. Right, and so we're going to focus on the free text narratives, and so I gave a little bit of a sense of why that is, but just to kind of highlight that a little bit, I think it's important to realize that the current way that we do this is asking the current way that we do verbal autopsies, where we focus on a structured interview, is asking the person, and in this case, a person who's recently experienced sort of something traumatic, to essentially translate from their experience and the way that they would discuss and talk about that experience into something that our machines can understand, right? So it's like we need, ones and zeros, yeses or nos, because that's what we can put into our statistical software package. And so we think that one of the, sorry, I'll tell the joke first and then, I shouldn't have let it go, the joke was coming. Tara actually, he left for this one. This one's so bad, he can't actually even say it. So I asked, I felt like I needed an image, so I asked the Google Slides Gemini AI for an image, a stylistic image of a survey. And this is what it came up with. So yeah. So I think if you were, if I were hanging out there with my feet in the water or whatever, then maybe if somebody came and asked me an hour-long questionnaire, that would be fine. But in general, I think that this sort of burden of doing the translation into something that we can, process in a computer, putting that burden on the human, does really limit the context in which we can ask these verbal autopsy surveys. So we want to try to use the free text narrative to get around that, because we think it's much easier. It's going to be much easier to deploy in a variety of settings and will dramatically reduce the response time. So this is just a summary of the whole procedure. So a death occurs in a community. Typically, there's a community informant that reports that to a health administration. An enumerator goes out, and then there's all of the research things that happen behind the scenes and the public health things that happen behind the scenes. about data processing and so on and so forth. Eventually it comes to the point where we're going to make predictions. So we've done our verbal autopsy interview, and then it's time to sort of make predictions about the likely cause of death. And then after we make predictions, we'd like to do inferences on those predictions, right? So we'd like to ask, does the intervention work? And just to give you a very concrete example of how that's used, so this is a paper from the CROI conference in 2015 with verbal autopsy data from three different healthcare surveillance sites. And the question here is about how does the distribution of causes of death change as you move across the rollout cycle of antiretroviral therapy. So the distribution of causes of death when ARTs are not available, as they're being rolled out, and as they're fully available. So this here is also interacted with male-female. So this is the kind of inference we'd like to be able to draw. We have an outcome, which is the cause of death, and we have some covariates. So antiretroviral availability, the sex, and the location. So that's a regression model at the end of the day. The outcome here is cause of death, and the covariates are the ones that you see there. So what are we going to do? We're going to use language models to try to predict cause of death from these verbal autopsy surveys. Then we're going to use correct the standard errors that come out of these regressions. We're going to correct the standard errors that come out of the regressions that we want to run afterwards. So when we want to get coefficients on, for example, does the distribution of cause of death change when you does it vary by location, or does it change when you roll out antiretroviral therapy? We'd like to be able to do valid statistical inference on those coefficients in this regression model. Because I sort of mentioned before that the prediction scheme is different than doing inference, but we still want to do inference at the end, right? Because we're still not seeing the whole population. The problems of inference haven't gone away. It's just that we're adding predictions on top of it. And so this is a bit different, or a bit of a caveat on the sort of traditional natural language processing kinds of problems, because we're interested here not so much entirely in the predictions, the quality of the predictions, but in how well we can correct the predictions to do inference, right? So what we want to know at the end of the day is, does the distribution of cause of death change as ARTs roll out? That's what we want to know, right? Like, I don't really care whether or not, BERT or Llama or GPT or like bag of words predicts cause of death the best. I want to know, does the distribution change as ART rollout happens? Okay, so this is just kind of formalizing this a little bit. So what we'd like to do is up here at the top. So this is the true outcome. We'd like to run a regression where the true outcome is regress on X. We actually have a prediction from an AI model, and we're going to use that as the outcome with X as the covariates. And so this is just a stylized example here to show that we expect to get differences both in the actual values of the, if we don't do a correction, we expect there to be at least potentially differences in both the values of the coefficients that we get and the standard errors on those coefficients. And you can think of sort of intuitively why that might be. So your model might do a really good job of making predictions for some cases, but a really bad job of making predictions for other cases, which is going to give you a systematic bias if that interacts with the covariates. And you definitely are going to underestimate the amount of uncertainty that you have, because you're pretending that each of those verbal autopsy, each of those deaths is recorded as a sort of ground truth, but it's actually not. It's actually a prediction that carries some uncertainty with it. So you need to take that uncertainty. So we're also going to deal with another issue which I haven't mentioned up to this point, which is transportability. And so that is sort of part and parcel with the prediction problem, right? We need some data to train the prediction model on. If the data that we use to train the prediction model on come from a different population than the one we want to do inference on, then there's a question of external validity. So we're gonna address both of these. here. Oh, sorry, I should have said that up better. Maybe this is the end. Just kidding. All right, so we're going to use data from something called the Population Health Metrics Research Consortium, which provides standardized gold standard verbal autopsy data. This is one of the very few cases where there are verbal autopsies collected along with sort of traditional sort of pathology and medically certified autopsies. So there's about 6,700 or 63 adult deaths. There are 6 different geographic sites in 4 different countries. There are 34 causes of death in total, but we're going to collapse those into 5 broad age categories, similar to what I showed you before. Okay, so this is the actual cause of death distribution across the 6 sites, and so you can see that overall so at the top you have non-communicable, and then external causes, which are like traffic accidents or that sort of thing. AIDS or TB related causes, communicable, and maternal causes. And I should say that the AIDS TB is sort of pulled out here because it's common for funding for these for verbal autopsies to be in exactly the context that I just described. So like thinking about ART rollout, so they're often tied to a specific sort of outcome, a specific cause. And in this case, HTB is a frequent one because you need to sort of do monitoring for a fairly long period of time to see the effects of the ART rollout. So that's why that one gets pulled out from the other communicable. And so what you can see here is that in across all the sites, the most common is non-communicable causes, but there's variation after that, and so that variation. You can sort of see here, this is going to be, it's a combination of like actual differences and potentially in size, right? So for example, here in this data from the Pemba Islands, there's only 260 causes. So it's quite possible that, that's compared to the, 1,500 or over 1,000 and all the others. So it's quite possible that there's additional noise here too, that's feeding into this. So we're going to do predictions with a variety of different prediction algorithms. I'll show you some results in just a minute. This is just an illustration of how we do it with a zero-shot GPT prompt. Adam has also been experimenting with the sort of few-shot approach. We can talk a little bit more about that in just a minute. We've been trying to kind of figure out the right, or sort of the best way to sort of go about getting valid predictions. But again, our goal here is kind of about the inference that happens afterwards, right? So here's a little bit about predictions. So you can see accuracy and F1 scores here. So you can see, naive Bayes, sport vector machines, k-nearest neighbors, the BRiTE NLP method, and then this zero-shot GPT. So what you can see here is that there are some differences in the scores. Overall, they're not great. I'll kind of skip through this a little bit, but a lot of this is happening because the text doesn't contain useful information. There's not useful information in the narrative in a lot of the cases. So a lot of the sort of classification performance is being driven by specific types of narratives. So for example, here are some of the things that people said. I should say I'm happy to talk more about what these, I did not give examples of what these narratives look like. I'm happy to talk more about that. I haven't found a way to read them without it ruining my afternoon, so I didn't want to do that for you all. But if you have questions about what it looks like, what they look like, I can talk more. But there's a lot of this kind of stuff. The respondent thanked the enumerator for visiting. The client had nothing additional to say. The client thanked the service, which provided at a particular hospital, and that sort of thing. So there's a lot of information in the narratives that's not salient for predicting a cause. And that of course, as you all probably know far better than we do, that sort of happens when you kind of move to this unstructured way of collecting data, right? So we love to talk more about what to do about that. Our strategy here in this case is to sort of remove those cases, which, when you do that, you end up with with classification that is very, very similar to what the sort of state-of-the-art algorithms can get in the context of in using the survey. So using this hour-long survey. Okay. Again, so this is, so the sort of the challenges of actually doing this. I'll actually just kind of move on. So our goal here though is not to just to make good predictions, it's to do downstream inference. And so this is a high level sort of schematic of how we do that. So we start with an upstream, a sort of black box AI ML algorithm. And I should say, this is not like us taking a stand on, we think fancy AI algorithms and black box algorithms are great. I think there's a lot of argument for using interpretable, machine learning tools. But the goal here is to make the inference correction not tied to a specific method. We don't want to make it so that, you can do inference if you use a neural network, or you can do inference if you use Lasso or whatever. We want it to be general. So you fit your algorithm, and we're sort of assuming that there's a gap in between here. It's denoted by, we should add some write-ups to the river down here. So there's an algorithm that's trained to predict Y, which is the outcome. And the prediction function here is what we're going to call F. And so we are sort of assuming that these steps are different, and that's contextually relevant in the verbal autopsy case, right? Because you often, it's very appealing when we go to clinicians and ask them about coding verbal autopsies. A very common response is a gesture towards the waiting room, right? Where there are, where there's lines of people who need services and are looking for help. And so there's understandably, it's hard to find time to prioritize coding verbal autopsies. So the amount of sort of data that you have in a particular location is going to be very limited. And so drawing from other data sources is going to be very appealing. And so in the context of verbal autopsies, you can think of this as saying you have a case where a bunch of people are, you have a case where you have a central verbal autopsy repository, maybe like the one that I talked about here. You're going to make predictions. The researcher is going to collect a very small amount of labeled data in the context that they have. The full amount of data that you'd like to collect, the full thing that you'd like to do inference with, is the combination of these two things. So you'd like to use both the deaths this very small number of deaths that you have labels for, and the deaths that you don't have labels for, where the labels are predicted from the algorithm. And I guess I should sort of pop up here because, one question that sometimes comes up is like, well, why don't you just do inference on the ones that you have labels for? And I think, the answer is because, we care about two things when we do statistical inference, right? We care about, type 1 and type 2 error, right? And so if we just use we could get 95% confidence intervals that have 95% coverage with just the cases that are labeled in the context that we care about. But we're sort of really, if we can make good predictions, we're leaving a lot on the table, right? We could potentially substantially reduce the width of those confidence intervals and increase our power, make it easier for us to detect effects if we can use these unlabeled data with reasonable prediction models. So then we have the prediction. So now we have predictions. So this F function, the orange here are our predictions. You notice here that critically at the top, you have this sort of this triple here where you have the labeled cases in the context that you're interested in, the predicted cases in the context that you're in, and the sort of covariance. And so what we're going to do in the third step is then use this triple to come up with a correction. So if we have a naive estimate for what the naive estimate for the parameter that we're interested in, the naive estimate just comes from taking the predictions, running a regression where the outcome is the predictions, and the covariates are the observed covariates. What we're gonna do is essentially use this trio up here, where we can look at the sort of how far off our inferences are when we use the predictions, and then we're gonna recalibrate back to try and come up with a way to try to come up with a correction factor. And I should say there's a few different ways to do this exercise. There's at least sort of 3 different approaches out there that are iterations of a similar kind of idea to try to come up with this correction. This illustration is based on it's actually based on some work by a group at Berkeley that we've kind of modified for this particular setting. But there's a few different ways to go about this, but the general idea is to say, let's look at how well we do in terms of when we do inference on the predicted outcomes in the case where we know what the true outcome is. Let's look at that difference and then build a calibration factor. And then what you wind up with is your estimate is essentially your naive estimate plus this correction factor, where the correction factor is all about the difference between the predicted outcomes the actual outcomes and the predicted outcomes, and how that varies with x, right? Because we might expect again that the model does really well at predicting for some x's for some cases, but not so well for others. So that's the idea. Here's what it looks like in the case of specific to verbal autopsies. So you have your cause of death prediction model in a label data set. The verbal autopsy narrative goes into the prediction model. The true cause of death over here comes up and gives you a correction factor that you can then apply in the unlabeled data set when you don't have any true causes. And so again, the sort of corrected parameter of interest is just the correction factor plus what you estimate in the naive approach. All right, so just to show you how this works in praxis. So we're going to use the data that we talked about before. We're going to introduce this transportability idea by training on 5 sites and predicting the 6th. We're going to introduce some model error by using the AI predictions for the cause of death. We're going to pretend like we don't know what the cause of death looked like in the 6th site. We do know in this case, this is again the sort of rare gold standard, so we know what the true answer is. We can compare our predictions to the true answer. And we're going to use the language model predicted cause of death with the correction, and the language model predicted cause of death without the correction, so we can kind of see the full gamut, the naive, the corrected, and the sort of grounded truth. So this is what it looks like in the sort of picture that I showed you before. So we're going to use narratives from these 5 sites to train a prediction model that will then apply and make predictions in the 6th slide here. We're going to take out 20%. This is sort of these are the sort of decisions that one makes when constructing these experiments, right? For kind of methodology illustration purposes. We can of course make different decisions about the fraction of labeled and unlabeled and that kind of thing, but we're just going to use an 80-20 split for the sake of this. So we're going to look at a case where we do multinomial regression with just one factor for illustration. So the outcome here, since it's cause of death, is multinomial. It's one of a set of categories. We're going to say that we're going to look at the multinomial regression coefficients on age, and so the question here is sort of do we see variation in cause of death associated with age? We would expect that we should. We're going to leave out HTB as a reference category, and so then the interpretation here of the thetas is going to be so for theta 1, for every 1 unit increase in age by years, the log odds of communicable compared to the reference, which is HTB, increases by theta 1. Same thing for the others. So just your sort of standard multinomial regression sort of setup. All right, so this is what this is what the outcome looks like, the output looks like. So, so here are the coefficients associated with, so you'll see each of the causes here. So remember, these are with a reference, to HIV/TB. So, we have three different sets of results. The ground truth is the sort of what you would like to have ideally. Naive is not using anything. The naive is sort of using the predicted outcomes only. And then the correction is the one here in purple. And so what you can see here is that, oops, sorry. So what you can see here is that, in this particular case, in the case where we're holding out this health surveillance site from Uttar Pradesh here as the one that we're predicting, you can see that you do see some variation in the coefficients. So like here in particular, in the case of non-communicable diseases, you get a fairly different, the naive here is going to give you a different, the confidence interval between the naive and the ground truth, which, I think I'm far enough away from the stat department, I can make that statement, and probably they take away my statistician card for comparing confidence intervals that are made in dramatically different ways. But if you wanted to, if you wanted to have like a gut check of like, are these, is this going to be would you make a different set of inferences depending on the method that you used? Then, here you're saying that you definitely would be, in the case of non-communicable diseases. For others, not so much necessarily. But this is just one example. Other examples, you start to see very dramatic differences. So, this is
Night base.
Oh, sorry. Yeah, I forgot to say that. So we're changing here not the location, but the prediction algorithm. So this is GPT-4. If you happen to use a naive Bayes prediction algorithm, the differences are very large. And so, so here, this is like, I think I could say these are different and still keep my statistician card. And here's similar kind of thing here for the external buckets. So the sort of substantive, the point here is that you're getting to the order of magnitude difference where, the kinds of substantive conclusions that you would make are going to be pretty different if you use the naive versus the corrected, is the first point, and the second point is that the corrected sort of brings you much closer to the ground truth. Okay, so that's kind of it. So this is the kind of the final set here to look at, right? Is that if we were to naively use the predictions, we'd end up with conclusions that are very different than the ground truth. But if we use this correction that's based on this idea of kind of recalibrating based on the sort of that triplet of overlapping data, we can get back to very close to the ground truth. Now you again see that there is more uncertainty, as you would expect, because we're using predicted outcomes. But the uncertainty is sort of fairly. We should actually do this. We'd actually look at the uncertainty that comes from just using the label data. But in most of the cases, in other contexts that we looked at, it sort of gives you a nice middle ground in terms of the width of the confidence intervals there.
Mhm.
Okay, so right, so that's really the sort of the end here of what I wanted to talk through. So the idea here again is that we have this approach to correcting for potential sort of bias and increased variance that comes from using predicted outcomes in the context of verbal autopsies. We think that could be used in a lot of different contexts, and are really excited to talk to you all about what that looks like. There's a lot of future methodology work to do here in terms of how do you combine different sources of information, how do you kind of think about sort of more complicated models. We're doing regression models now. Some of the other folks on our team are doing things like looking at survival models and things like that to kind of get into some of the other contexts. And there's also lots of open and exciting questions about how you think about using these ideas to sort of design interventions, right? So if you're using predicted outcomes to sort of then go forward and do design for interventions and that sort of thing. So I think there's lots and lots of really important sort of methodology work to be done here, as well as as well as some scientific work, which is one thing that I think is great about our group is that we can we're sort of situated between the stats and sociology departments, which gives us the leverage to kind of be able to do a little bit of both of those, which is fun. Okay, and I think that's it.